Good afternoon, everyone, and welcome to this Thrombosis UK virtual conference and this webinar on the occasion of National Thrombosis Week. This session is on reducing hospital-associated thrombosis and learning from the GIRFT thrombosis survey. I am Roopen, Arya, I'm a hematologist at King's in London, and I've had the privilege of contributing to the National VT Prevention Program for 10 or 15 years now. It's over a decade since the launch of the National VT Prevention Program in England, when VT prevention was made a key patient safety priority. And by introducing a system-wide approach, we have ensured a consistent approach to risk assessment. And for the first time anywhere in the world, we've demonstrated an improvement in patient outcomes and a reduction in post-discharge VT deaths. So now VT prevention is embedded in the quality and safety structures in our hospitals, but it's essential that we continue to reflect on our practice and continue to improve, because hospital-associated thrombosis remains a major cause of patient harm in hospitals. And that's where the GIRFT thrombosis survey comes in. It is an important tool to evaluate and build on our current practice, and really as a project arose through a collaboration between Thrombosis UK, GIRFT, and the National VT Exemplar Centre Network. So we are fortunate to have some excellent speakers and a very expert panel comprising Lara Roberts, who's a consultant hematologist at King's and VT lead at King's College Hospital as well. So I think Lara will commence with a presentation, after which I'll introduce the rest of the panel and we can have a hopefully lively discussion. And I'd encourage you to submit your questions either via the chat or the Q&A, and I'll do my best to monitor the questions and try and ensure that we have as many replies. So over to you, Lara, to talk about the GIRFT thrombosis survey.
Thank you, Roopen. So as Roopen has already said, I'll get my slides to work. The National VT Prevention Programme in England launched just over a decade ago, and it was the implementation of mandatory documented VT risk assessment, which defined the approach with central reporting and a financial penalty for failing to meet a 90% risk assessment rate. This was supported by comprehensive guidance issued by NICE, along with a quality standard defining best practice in VT prevention. And there was a call for root cause analysis of all episodes of hospital-associated thrombosis to further drive quality improvement. And the aims of the programme were to reduce avoidable death, disability and ill health associated with hospital-associated thrombosis, and also to embed VT prevention into our routine clinical care. And the VT risk assessment remains in the NHS standard contract today. So we saw within just over a year from the introduction of central reporting of the VT risk assessment rates that the 90% rate was met at a national level. And that's been maintained. The target was increased to 95% in year 3, which was again achieved and was maintained at the last reporting period, which was Q3 2019-20. But at that time point, 28% of hospitals didn't meet the 95% risk assessment target. So there's possibly been some drop-off in quality of care. And as Roopen mentioned, the NHS Outcomes Framework Indicator measures deaths from VT events within 90 days of discharge. And over the reporting period, we've seen a 16% fall in post-discharge VT deaths. But there remains a lack of national data about what happens in between, so between that VT risk assessment and provision of thromboprophylaxis, which was what we aimed to look at with the GIRFT thrombosis survey. So I'm not going to present all of the findings today, but I will talk about provision of thromboprophylaxis, both mechanical and anticoagulant, patient information, the clinical areas and rates of hospital-associated thrombosis in those areas, and then themes within the potentially preventable HATs. Just a reminder about this survey. It launched in October 2019, and we plan to run it for 6 months. It comprised 3 surveys. The first was an organisational survey of VT prevention resource and local practice. There was then a prospective survey of VT prevention practice, where patient-level data was submitted, as well as a separate survey for hospital-associated thrombosis. And then, of course, we started having issues with COVID in February, which was impacting on submissions to the survey. And we also noticed that COVID was associated with a lot of VTE. So the survey was extended to allow us to capture some of that data just for the hospital-associated thrombosis until the end of May. And we also extended the data submission deadline till August to give people more time to submit their data. I'm just going to focus on the NHS findings today. Of 144 trusts invited, there are 103 participants, which included 96 unique trusts and 7 reporting data by site. And I'd just like to thank anyone listening who took part for your contribution, because without everyone taking part, we wouldn't have any data. But whilst participation was high, just to also acknowledge that it's not complete, so we can't consider these findings to represent the NHS as a whole. So the second survey, looking at VT prevention, we asked sites to review 4 admissions associated with a high risk of VTE of each of the following types each month. So we're hoping to see 120 submissions per site. And there were 98 sites participating in this survey, and there was a median number of 85 submissions per site. Some exceeded the total number, but most were under, and I think that was partly due to COVID. We saw a significant fall off in the final months of the survey over February and March. So looking at whether mechanical prophylaxis was indicated, this did vary by type of hospital admission. So medical inpatients, 22% of those surveys were considered to have an indication for mechanical prophylaxis, compared to 72% in surgical patients. But it's interesting that medical and obstetric patients were still considered to have an indication, given that in the latest NICE guidance, it's no longer recommended to use mechanical prophylaxis. 2/3 of prophylaxis indicated was stockings, and then IPC was considered indicated in 17%. And again, there was wide variation in findings across sites. So some sites reporting indications only 40% of patients surveyed, up to 100% in others. And then we looked at the quality standards mentioned in NICE about whether stockings are fitted and monitored in line with NICE guidance. And overall, 70% of patients surveyed had stockings fitted in line with NICE guidance. 15%, the person completing the survey was unable to determine whether they were fitted in line with NICE guidance or not. And about 5% of the time, they were not fitted in line with NICE guidance. And there's a little bit of regional variation in this, but between sites, there's huge variation from 0 all the way up to 100%. Looking at anticoagulant prophylaxis, we only considered this in patients with a low bleeding risk. So this was just over 7,000 patients. And overall, 88% of patients had thromboprophylaxis prescribed appropriately. And there's not a lot of regional variation, but quite a big difference between individual sites, with some only prescribing in 40% of patients. We're also interested in the delivery of prophylaxis, and again, in the latest NICE guidance, they recommended that the first dose should be given within 14 hours of admission. So this was sort of 6 months after that was published, and we weren't generally as good at doing that. So overall, it was about 60% of patients receiving first dose of prophylaxis within 14 hours, again with very wide variation between sites, so ranging from 1 up to 100%. And we were also interested in missed doses. So we asked whether any of the patients had had missed doses, and overall about 7% of patients had missed doses, with some variation from between sites, so from just under 5% up to 12.5% of patients having missed doses. And again, if you look at individual sites, this varied from no patients to 55%. And looking at patient information, overall only 30% of patients had evidence of receiving written information at the time of survey, again with variation across regions and very wide variation between sites, so with some sites not having record of any patient information having been given. Moving on to the hospital-associated thrombosis, there were less sites, so 84 sites participated in this aspect, with just over 4,500 episodes of hospital-associated thrombosis submitted. And the number reported per site varied quite widely, so some sites reporting only one event, up to 277 with a median of 43. And again, it does look as though COVID impacted on participation here, in that we saw there were less hats submitted from February. But overall, the median rate of hat was 1.7 per 1,000 admissions. And if you exclude sites with very low numbers of cases reporting, we only ended up with 36 who had more than 50 cases. But that then increases the rate to about 2.3 per 1,000 admissions. And we looked at it by patient type. This is now excluding day cases, where the rate is much lower. The rate in medical patients was about 4.5 per 1,000 admissions. In surgical, it was about 3 per 1,000 admission, and in obstetrics, it was 0.69. And then moving on to the underlying themes of the hats, the greatest proportion of these actually received appropriate thromboprophylaxis and still developed a hospital-associated thrombosis despite that. 13% were associated with inadequate thromboprophylaxis, and a similar proportion with a contraindication to thromboprophylaxis. There was a much larger group than we'd anticipated who were recorded as being unexpected. We'd put in this category for patients really who had been identified as not having a high VT risk, but most of these were actually patients who were on appropriate thromboprophylaxis. So I think there was a bit of the classification not being used as intended. And there was a small proportion of patients where the investigation wasn't complete or it was associated with a line. And looking at the proportion potentially preventable, overall it was 13% were considered potentially preventable. Again, there is regional variation. The line in blue is including all centres, and the bars in red are those reporting more than 50 episodes of HAT. And that does impact a little bit on the proportion considered potentially preventable. And you can see the variation between individual sites comes down if you exclude low reporters. And then we tried to look at underlying themes within those that were considered potentially preventable. And the comparator in red is still patients with a hospital-associated thrombosis. So we don't have a comparator without hospital-associated thrombosis. But not having a risk assessment on admission seemed to be associated with potentially preventable HAT. The other themes were thromboprophylaxis not being prescribed when it was indicated, or there being a delay in thromboprophylaxis or missed doses. And there were quite a number of centres who reported wrong dose per weight, and particularly in surgical patients, post-discharge prophylaxis not being prescribed was considered to be a contributor. So there are limitations to the survey in that the participation was entirely voluntary, and the data reported is entirely dependent on the quality of that entered. We didn't do any data cleaning. I think it's highly likely that COVID impacted on completion of the survey. We saw the numbers fall off during the COVID pandemic, and that may have contributed to some of the centres not contributing all of their HAT data. And the sort of broad variation in the numbers of HATs suggests that either some centres aren't identifying all of those episodes or they weren't able to contribute all of their data. So the recommendations that we're proposing in the report that will be released soon, I didn't talk about this, but almost a third of hospitals participating don't have a VT prevention role, so we're suggesting that that should be developed, and that hospital-associated thrombosis should be routinely identified and investigated, and we're asking centres to look at their rate and consider whether their rate compares well with other centres, or if it's low, whether that may have been due to under-identification of HAT or just an inability to contribute all cases. There's a need to improve our provision of patient information, of both written and verbal. We're suggesting that hospitals still using medical stockings in medical and obstetric patients review that practice. There's a need to reduce the number of missed doses of anticoagulant thromboprophylaxis. And we're also suggesting that non-exemplar centres could buddy up with a VTE exemplar centre to build their local practice. And I'm sure the panel will give some further ideas about that when we move on to the panel discussion. And then at a systems level, we're hoping that NHS Digital will soon reinstate the data submission for VT risk assessment that was paused again due to COVID. And it would be useful to look at the impact of electronic prescribing on missed doses. So not everyone has access to electronic prescribing, but that may be a lever to reducing missed doses. Joe and Thrombosis UK are working on developing an educational support programme to identify some of these areas. NICE are due to publish an updated quality standard for VT prevention, so we still don't know the final content, but we will liaise with them if it doesn't address the areas that have been identified as needing improvement in this survey. We're going to look at whether we can change coding to help monitor rates of HAT more centrally by including a code for whether a VT was present on admission or not. And we'll also submit some research recommendations to NIHR. And we're still waiting, but we're hopeful of having funding for a repeat survey so that we can see whether people have been able to improve practice based on their local findings. So in summary, this is our first insight into real-world VT prevention practice in England. It does highlight that there is significant variation. Overall rates of appropriate anticoagulant prophylaxis were very high, but there was significant variation in delivery of prophylaxis, both in terms of giving it within 14 hours of admission and in the numbers of missed doses. There's a clear need to improve delivery of patient information, and there was wide variation in rates of HAT, with a significant proportion still potentially preventable. So there's still work to do. So I'm going to stop sharing my screen and hand back to Roopen to introduce the panel.
Thanks, Lara, for an excellent presentation. And I'd also like to thank the GIRFT Thrombosis Survey team that really have done an excellent job, in what is a big challenge to try and survey VT prevention practice to iron out the variations in care. So now I'd like to introduce the panel. So we have Emma G, who's a nurse consultant in thrombosis and anticoagulation at King's, who is also the lead for the VTE National Nursing and Midwifery Network. And then we have Rebecca or Becky Simpson, who's the lead nurse for VT prevention at Ashford and St. Peter's NHS Foundation Trust, which She joined a few years ago and achieved exemplar center status, I think about 5 or 6 years ago. And I remember a very memorable visit to Ashford and St. Peter's. And last but not least, I'd like to introduce Andrew Gillett, who's the lead VT specialist nurse at Stockport NHS Foundation Trust, who are the most recent addition to the VT Exemplars Center network. So congratulations. You are, I think, the 36th center, which makes it about 2.5 centers, that have been awarded the status every year since the Exemplar network has been in existence. And you've done a fantastic job at Stockport, and there's many aspects of care, both from VT prevention as well as the VT ambulatory care, in which you excel. So you've been the lead VT specialist nurse for the past 11 years. And really, Emma and I were not able to visit on this occasion due to COVID times, but hopefully we will be able to meet face to face one day. So that is the panel, and feel free to put questions in the Q&A and in the chat to ask the panel. But I think I'll kick off maybe by asking Rebecca how you found the GIRFT thrombosis survey to complete. I mean, was it a user-friendly process, and did you find it profitable?
Yeah, I mean, it was very, very user-friendly platform. We found the platform really simple to use, actually. Very simple, very intuitive. I can't take credit for it because quite a lot of my colleagues did the majority of the data entry. One in particular, Joanna, she found it a really, really useful experience, actually, in terms of providing opportunities for further discussion, as well as collecting all the data that was so important in generating the themes and the information that Dr. Roberts has just presented there. It provided lots of opportunity for further discussion between us as a VT prevention team and our colleagues and patients and their carers at the time when it first started, because obviously that was pre-COVID. It became much more of a challenge when the pandemic did start to arise, because we had to face, capacity challenges and staff redeployment, which made it a bit harder. And as Dr. Roberts was referring to earlier, perhaps didn't have a full submission, which we were really disappointed about, because we were really keen to see a full data submission there. But yeah, we found the process really simple and really beneficial, particularly in terms of those opportunities to open up the discussion that perhaps we wouldn't necessarily always have.
Did you find any of the results surprising or not always recognizable?
I think for me, there were 3 areas overall that I found particularly surprising. One was the number of units who are routinely identifying and reporting HATs. It was much lower than I actually thought that would be. I found that surprising on a national level. Nationally and locally, I found the level of patient refusal quite surprising. I didn't realise quite how high that was. And I don't know if we're going to go on to talk about some improvement work later, but we're doing some improvement work around that, linking in with patient information. But I found that really, really quite surprising, considering all of the resources and the information that we do have available.
Yeah, perhaps we can discuss that in a little more depth in a moment. But I'd like to also pose the same question to Andrew. Just building on the theme of the GIRFT thrombosis survey, because we haven't had any system levers in VT prevention since the sequence, and so it was very important that we had something to kind of drive the agenda, which is why I think the GIRFT thrombosis survey came at an important time. Andrew, may I ask you what your experience was of the GIRFT thrombosis survey and what learnings there might have been for you?
Yeah, I mean, I think personally, and sort of working closely with quite a large thrombosis committee that we have at the hospital, it's been a bit of a game changer, really, because we were kind of using a sort of tool that we put together ourselves, so that we could report any sort of incidents of HAT through our local incident reporting system, and that was okay, but the feeling was that the HATs were getting sent out to the named consultant of the patient who may have seen them 30 days, 90 days ago. And it was just impossible to get these people to sit down, go through the notes, go through the records, and give you a full, answer to the question we were looking for. So with a standardized tool, it's been really, really straightforward. Like Rebecca, I've not, been sort of actively doing them, and my colleagues have been more involved, but we've had kind of named consultants from each speciality who sit on the committee, and they found it incredibly useful and incredibly easy to use. And from a reporting point of view, it's brilliant for us as a committee, because we can sit down and we can kind of go through the results ourselves, and it almost answers what quality improvement things you need to do as a trust. And that's been really effective to us. It's shown us the areas that we're not doing particularly well in, and we've thankfully made strides to improve.
And you've incorporated the GIRFT root cause analysis tool into an electronic format, have you?
Yeah, that's right. Yeah, so we use this now for all our VT reporting as our standardized tool now. We don't use the old tool. We still record, we capture the data over a 90-day period as well. And that's particularly useful for, as I say, for reporting purposes, quality assurance, but also improvement. We know where we're, the areas that we've got to improve in.
No, because I mean, to me, I've always been passionate about identifying the hospital-associated thrombosis, because it makes you aware of what the real burden of disease is in your hospital, and also where there are issues or systemic themes that need addressing. But equally, I think it's also a difficult area to look at a national level, because there's undoubtedly ascertainment bias, because the centers that are more interested in quality or have more resource that they've channeled into VT prevention are more likely to pick up cases. So I don't think, if we take an overview, it means that centers with fewer hats are doing anything right or doing anything better. So I think there's a kind of balance in there, and which is why I think we did reach a bit of compromise as to how we did put it out in the GIRFT thrombosis survey, because there is ascertainment bias, but there's also a lot of learning, as to when things go wrong and what to do about it. And also, clinicians need to take ownership for when things go wrong, and particularly if there's any kind of failures in care. So it's your feedback is very interesting, and hopefully we can build on it and have another follow-up survey, hopefully when the COVID numbers have declined a bit. So Emma, on one of Lara's slides, she mentioned how the VT Exemplar Center Network might kind of be able to help. Because I think one of the things about GIRFT is to try and iron out, the variations that were very apparent from Lara's slides, either in the amount of resource that were available or in the actual performance. So how do you see the VT Exemplar Center Network contributing to this?
Yeah, I agree. It's important that we strive for consistency nationally. A patient being admitted into a hospital in London should have access to the same care as a patient admitted to a hospital anywhere else in the country. And I think that now we've got 36 VT exemplar centres and more applying to join all the time. I think that part of the criteria to become a VT exemplar centre is that you display leadership and support local hospitals and organisations also wanting to achieve high standards of care and VT prevention. So I think they're ideally placed to support centres with their GIRFT findings. I think a buddy system could work well. I can see hospitals linking up with either a local hospital that perhaps they already have links with, or a hospital that's similar to them in size and structure, for the VT leads, if there are leads at both sites, to get in touch and perhaps jointly come up with an action plan if there isn't already one in place for that centre, and to have regular meetings to check how outcomes are going, to support in terms of giving ideas, potential solutions. And I think because the Exemplar Centre network has access to each other, and in the nursing and midwifery network, we've actually opened that up to anyone interested in VT prevention. It's there as a resource, so people can join and share those ideas amongst each other. So I think that could work really well.
Yeah, no, I'm always marvel at the responsiveness of the NNMN. You know, in that if you put out a clinical query, you've had a host of replies by the end of the day, isn't it? You know, because there's so many different ways to skin a cat, as it were.
Absolutely, and no point two centres doing the same work. So, you know, creating new information leaflets, sharing audit tools, that kind of thing. It just makes the work a lot more effective and efficient for everybody.
Yeah, so I quite like this idea of this kind of buddy system, and that you are always updating the website as well, aren't you? The Exemplar Centre website, which
Yes.
does host a lot of resources from the Exemplar centres that people might find useful. Yeah,
It does, yeah. vtengland.org.uk. There's a wealth of information on there, but yes, probably one of the most useful parts of the site is the resources. So there are patient information leaflets, audit tools, all sorts of information that might be useful. And also there is a way of getting in touch with the rest of the network on there as well, if people would like to.
yeah. So thanks for that, Emma. There's a very constructive response on chat from Careway Link, who say that they did the GIRFT VT survey for their hospitals and the process was fine, but the most difficult was to find files for patients that were, quote, missed, unquote, on the day of surgery. And we used our electronic VT assessment and iAuditor platform to gather the data, which was very useful. The support by email was excellent, and any query was replied to very quickly. And I would absolutely agree with the Careway people. You know, I think the GIRFT team are fabulous and very, very responsive, I think, and much more agile than, you know, we are accustomed to from the NHS powers that be, you know. So, and Careway also have a question to you, Emma. Which platform do Exemplar centres use to communicate? Yeah.
We use email. So on there, if you head to the nurses page on the VTE England website, there will be a form to fill in order to request to join the network. And then I will just add you to our distribution list.
Okay.
But by all means, contact me directly if need be.
Yeah, yeah. And so now I'm informed that Careway is actually quite a superstar in the world of thrombosis. It's Stefan Jaglin, who has done a lot to improve the care and coagulation and VT care of patients. So welcome, Stefan. Nice to see you on the chat, and keep up the good work. And really, we are always, I think, in this game, learning from each other. So I think I'll move on. Clearly, COVID has kind of dominated our lives in the past year, and certainly at the peak at King's, we were looking after about 3 times as many pulmonary emboli, you know, as we are accustomed to. and there's been a very, very big burden of thrombosis. And earlier this year, just as we thought things are getting better, there's been this issue with vaccine-induced thrombosis, thrombocytopenia syndrome that, some of us were seeing patients. It is a rare condition, but there have been nationally, I think 240 plus cases described. And so I think there were the pressures of not only dealing with a syndrome which was described for the first time, but also from the kind of hysteria, generated by the media. For example, we were having about 30, people with mild post-vaccine headaches presenting to ED every day, in the first few days after the media coverage. So that has thankfully settled. But COVID did impact, as Becky pointed out, on the data collection for the GIRFT thrombosis survey. But maybe I'll invite Lara to comment a little more broadly on the data that we did collect during the COVID times in the GIRFT survey. Lara?
Sure. So there are about 450 episodes of hospital-associated thrombosis associated with COVID reported. And using links to hospital episode statistics data, we were able to calculate rates of VTE in that group compared to pre-COVID. So we looked at the October to December period medical admissions, and it was about threefold higher, even just in the cases submitted to the survey. It's difficult to know, obviously, whether we captured all of those events because people weren't submitting them all, and that may underestimate. The other interesting finding was that the HATs associated with COVID were more likely PE, so about 73% of HATs in COVID were PE compared to about 50 in the non-COVID cases. In retrospect, it might have been nice if we'd asked for extensive PE, because we didn't do that, but I suspect many of those will have been segmental and subsegmental, given the understanding now of immunothrombosis. And most of the patients so about 85% of patients with COVID and HAT had received at least thromboprophylaxis, with some of them receiving therapeutic or intermediate dose Plexane, or not just Plexane, heparin.
Okay, but clearly, I think the process was overwhelming our standard thromboprophylaxis practice, which is why I think a lot of centers did switch to the use of intermediate dose low-molecular heparin in particularly the critical care patients. But it has been a very dynamic and at times confusing area, particularly with results now being shared by Twitter, sometimes months in advance of the publication of the kind of peer-reviewed papers. So, the multi-platform studies recommending therapeutic dose anticoagulation in the ward patients, I think, is a case in question. But there is a question from Joseph that some patients are diagnosed with PE on admission, as is common to COVID patients. Would you do root cause analysis?
Sorry, I should have made that clear during the presentation. So we only consider event to be hospital associated, either if it occurs following discharge, so within 90 days of discharge, or for surgical patients if it's post-procedure, and for non-surgical patients if they've been in hospital for 48 hours or more. So if someone was coming in with a first hospital admission and was diagnosed with PE on admission, we wouldn't consider that hospital associated, because there's no opportunity to prevent that.
Yeah, but as Joseph points out, I mean, in the COVID patients, there are the issues about thromboprophylaxis, but many of the patients on the wards with pulmonary embolism, probably had it on admission to hospital. Didn't you find that in the data that you published last year?
There are numerous publications that have looked at VT and COVID, and I think those that have looked at the timing suggest that about 40 to 50% of VT is present on admission. I don't think we will have captured the data well enough in GIRFT, because if they hadn't been admitted, they shouldn't have been included. There were a handful of cases where it looks like the diagnosis date coincided with admission date, but we wouldn't really consider those to be hospital-associated thrombosis.
Yeah, and also, I suppose what has changed between the first and the second waves is that everyone is now thinking of VTE. So maybe there's an ascertainment bias as well, isn't there? You know, that you've gone from, you know, a very high percentage of positive scans to a much lower percentage of positive scans, isn't it? You know, so.
Yes, I think that's our experience at King's in the first wave, particularly early in March, when we were still learning about the disease. There was a reluctance both to move patients to radiology to sort of limit cross-contamination, but also with the staffing pressures, not having enough nursing resource to do that safely. And so we had much less imaging occur in that wave, and I think about almost 40% of scans were positive. Whereas in the second wave, when we were more aware of the risk of VT and we got better at safely transferring patients and infection control procedures, it was only about 15%, which is about what we'd see in non-COVID times.
Yeah, and I think another important finding was that in our about 2,000 odd patients that we had looked at about halfway through, that post-discharge VT did not seem to be a big problem, isn't it? Because there's a lot of variation in practice between hospitals, even in London, on that, aren't there?
Yes, so again, our experience at King's was that it was an uncommon complication, and it was no different to the rates that we see following medical admissions sort of pre-COVID times. Yeah. We did try to look at that in GIRFT, but obviously the period with the COVID admissions was much shorter. We only had sort of March to May.
Okay.
But there was significantly less post-discharge VTE than compared to the medical admissions.
Okay, thanks for that. And now just circling back to some of your conclusions from GIRFT, particularly, you know, in our medication safety team at King's, we've always been worried about omissions of medication, and which can be particularly impactful in the VT prevention setting. Becky, you kind of mentioned that you've done some kind of quality improvement work around that. Would you like to share that?
Yeah, absolutely. Yeah. So we've done a lot of quality improvement work around medication safety in general, and particularly around omitted doses of thromboprophylaxis and anticoagulants over the last 2 years, and we've kind of got the kind of unexplained or inappropriate omissions down very low just by doing really, really simple things. And a lot of that was to do with communications between professionals, teams and the patients themselves. But what the GIRFT showed up for us with regards to missed doses was around patient refusal, which we hadn't actually, although it's a slight aside, we hadn't given it that much emphasis as opposed to the unexplained omissions. And actually it prompted us to look back retrospectively in cases where patients had refused their prophylaxis, and we delved into them in more detail to look at why. So did they have enough information to make those decisions? And it also raised the issue around capacity and whether people have the capacity to make those refusals. And particularly in our cohort of patients that we have kind of a lot of older people that utilise our services to our hospital, that may have transient interruptions to their cognitive state and things like that. We found that a lot of patients were perhaps assumed to have capacity where they may not have done, and that made the refusals in effect inappropriate, and it's prompted an awful lot of work with our safeguarding team. And at the moment we're putting together some criteria and working very, very closely with them to look at how we can perhaps try and tackle it. It's very contentious, it's very tricky, because obviously there are lots of kind of multifactorial things that are, but I think it's going to be really, really important in keeping specifically our cohorts of patients safe in regards to these doses that perhaps should have been actually administered when they weren't.
Yeah, no, it's absolutely critical, and I'm aware, of numerous incidents where there were sadly very bad outcomes, from that as a result of these omissions. So
yeah, often refusal taken as a refusal, isn't it? And sometimes that really isn't in the best interests.
Yeah, so I think the patient information has always been a challenge for us at a national level, because it is one thing having a patient information leaflet available in the hospital, but the patients have so much going on that usually it's at the bedside table, or it's not being necessarily discussed as a risk with the patient. And unfortunately, we were constrained within the GIRFT process of not being actually able to ask the patients anything, because that's not the way the process is meant to work. So we had to rely on what we were told in the feedback. So, and Andrew, would you like to share again? I recall in your presentation recently, quite a bit of work around patient experience at Stockport.
Yeah, and I think that's been quite key to the the sort of studies we've done around GIRFT and things, is that the lack of patient information. We've always had patient information in preoperative clinics. We've had them in obs and gynae, but on general medical surgical wards, nothing really out there. So we've set about creating a sort of very generic information leaflet, which is handed out to the patient on admission. And we've made it part of the admission pack as well. So it kind of empowers the nurse or the doctor to hand that to the patient. I guess the content of it does again sort of empower the patient really to ask, why am I not receiving this treatment? Why is the woman in the bed next door wearing stockings and I'm not? So it has been quite well received, to be honest with you. And I think we're due to audit this very, very soon. It's probably been a good 12, 18 months since this went live. We're finding that, as a result of the GIRFT, that kind of has caused a discussion on the thrombosis committee. We got on with a sort of quality improvement project. And we're hoping to see that, this has just become a mainstay now, that people are getting information as soon as they come into hospital.
Yeah, no, I think, the patient information and the repeat risk assessment have been things that we've always, I think, as a system struggled with, and we have not solved as yet. We have Joe Jerome with us from Thrombosis UK, and clearly, the patient information and having the patient at the center of everything we do is what she does. So would you like to comment on, how we are going to take the results of the GIRFT thrombosis survey and build on, clearly what is a deficient area in healthcare? Yeah.
I think Thrombosis UK were disappointed, but I don't think we were surprised to see GIRFT. And in some ways, GIRFT, I think, empowered us further to actually show evidence that this is an area that is woefully lacking in many regions of the UK. And I think for our role, it's really important. Obviously, we work with patients, but we also work with all the clinicians to put together materials which often we have, but are best suited and be flexible to how it's presented. So whether it's online, in print, small booklet, etc. We've already had one booklet that we've worked with another VT exemplar centre in Wales with around reducing your risk of VT on being admitted to hospital, and to see what variety we can put there and support being put there to help across different departments and different centres. And I think the education package, I know we're going to work together on from the report, will also focus on patient information, the bare minimum and the ideal to provide, and the formats. with that, what I would hope is that we would really, and I use the word strongly, we would really lobby NICE and others to bring this in, to find a way of bringing this into quality standards as an incentive to provide, because it's so beneficial. So for us, it was very disappointing that GIRFT showed it, but also a very useful tool, because we this is what we hear all the time.
Yeah, and this is what we are here to sort out together, isn't it? So I think yeah, it's a very important piece of work, and no shortcuts. I suppose COVID has increased the awareness of venous thromboembolism, though probably not always in the right way. And what you hear, if you're panic stricken, is quite different from what we want people to hear. That usually there's something that we can do about it, and often there's something we can do to prevent it, and people should seek care early. Those are all the messages we need to get across, really, isn't it?
Definitely. I mean, nobody would have wished for COVID, but it has really focused on thrombosis and across the general public as well. And I think this is something that we've all responded to, and we have to keep doing this.
Yeah, and I think it will probably also impact academically, on furthering research in this area, because we know that despite all the risk assessment and giving 87% appropriate prophylaxis, that we are still seeing thousands of deaths from hospital-associated thrombosis and thousands of cases. So because the best of the current care is only going to prevent 50 to 60% of cases. So I think what we have learned from the inadequacies of the prophylaxis and of the dosing, and that maybe we need to refine our risk assessment process, to maybe identify that small cohort of patients that might benefit from an escalation of prophylaxis compared to, that larger cohort of patients who might not be at such a high risk as we thought, as surgical techniques are improving, particularly in orthopedic surgery, the historical rates, venographic DVT are completely unrecognizable to the symptomatic VT rates in modern orthopedic surgery. So I think, there is a kind of knock-on effect, and it has kind of accelerated research in the field, which I hope will benefit. So, just, I'm aware we have a few minutes. There's one question we've not taken up, which I'll get saved all the difficult questions for Emma. So for trusts who do not have VT prevention roles, how can we tackle introducing this and finding the funds for these roles?
Yeah, it's challenging, isn't it? In this day and age, trusts want to know what money roles will bring in to the hospital. And obviously this role doesn't necessarily directly generate income, but looking at the data and our experiences with dealing with centres across the country who perhaps in sequin days had a VTE prevention nurse and then subsequently lost their nurse, we know that having a nurse or a VTE practitioner lead in the trust really helps to keep up the momentum, helps to keep up the high standards of VTE risk assessment, learning from HATs. So I suppose it's difficult, but we have helped, as a network, we have helped people before that have tried to get roles for their trust. So by all means get in touch and I might be able to provide some support and some resources. I think it's looking around your own data and looking at where the gaps are currently. And also there is plenty of evidence now across the network that actually having a practitioner in post does help to improve standards. And obviously as Lara presented the reduction in post-discharge VTE death data. Again, I think the arguments are stronger than ever now, and GIRFT has further supported that having a VTE practitioner in post can really help to drive up and maintain quality standards. Because we know that in the best centres, if you don't have somebody in place, those standards can slip. And also, new things are happening all the time, aren't they? Policies are changing. Staff turnover is very, very high. So our VTE nurse specialists are very busy trying to reach new staff and trying to support staff during, for instance, the COVID pandemic, where things were changing and people had lots of questions about thromboprophylaxis and blood clots. So by all means, get in touch. I don't think there's one sort of magic bullet for this, but it is really around risk reduction and reducing the risk of patient harm rather than income generating.
And we can share examples of job descriptions and business cases, I'm sure, isn't it? And Thrombosis UK also shared an important piece of work, about the amount of litigation and payouts that trusts have had to do around, serious cases of hospital-associated thrombosis. So I think that is also a wake-up call to the trust. But I think getting it right first time, as a process and as a mechanism, as a tool, it really does get taken very seriously at the board level in trusts. So do use it, do use it for the advantage of the patients within your trusts to improve the care of the patients and to improve patient outcomes. So I'm aware that we are kind of approaching the end of this. Any last words from any of our panel?
Can I just add something about patient information? I think that it's relatively easy to tick the patient information box by giving patients leaflets, putting on the discharge summary. But what we know is that, as you said, Roopen, thromboprophylaxis isn't 100% effective. Patients will still be getting blood clots. So we need to really make sure that patients are understanding the information. And if they're not inclined to read a leaflet, we take every opportunity during their care episode to give them that information verbally. For example, somebody who is on low-molecular heparin daily, every single time you go to administer that injection is an opportunity to say to the patient, this is to reduce your risk of thrombosis. The signs and symptoms of thrombosis are, because we really need patients to understand that early detection is going to be key to preventing any harm from VTE.
Yeah, I think that is a very, very important message, and really, is also linked into what we've been trying to communicate around COVID, because it makes a huge difference, to the outcomes. Great. If there aren't any further points, I'd like to thank all the attendees for joining us today. And I'm immensely grateful to our wonderful panel, Lara, Emma, Andrew, and Becky. And a big thank you to Thrombosis UK and to Joe and all the trustees of Thrombosis UK for allowing this to happen, because National Thrombosis Week, but also thrombosis is an important issue for all of us and for our patients every day of the year. So thank you all.